Welcome to this Step 3 review on outpatient clinic management test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam when you are managing patients in the clinic over time and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the ambulatory medicine and preventive care sections of your primary review book and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems that test outpatient clinic management. Second, we will apply specific strategies for telling apart initial visits from follow-up visits, for managing chronic disease, and for medication reconciliation. And third, we will master the next best step question format for health maintenance scheduling and longitudinal care. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the initial versus follow-up visit split. When you see an outpatient question, immediately ask yourself, is this patient brand new or are they already established? For an initial visit, look for phrases like new patient, establishing care, or first visit. These stems reward the broad foundational work: a complete history, a full review of systems, baseline screening, and a thorough medication and allergy list. For a follow-up visit, look for phrases like returns for routine follow-up, here for reassessment, or known chronic condition. These stems reward the focused next step in ongoing care, such as checking whether goals are met, adjusting therapy, or timing the next screening. Deciding which kind of visit you are in tells you whether the right answer is broad or focused, and that single decision often eliminates half the choices. Strategy 2 is the chronic disease management approach because the boards test this constantly in follow-up questions. The trick is to find the measured value in the stem and compare it to the target. If the value is above goal in a patient who is already on therapy and adherent, that is a goal not yet met scenario, and the right answer intensifies management. Increase the dose, add another agent, or reinforce lifestyle change. Do not simply reassure and continue the same plan when the number misses goal. If the value is at target and the patient is tolerating treatment well, that is a goal met or stable scenario, and the right answer continues the current plan and schedules appropriate monitoring or the next routine screening. When something is controlled, resist the urge to add or change medications. The exam rewards both intensifying when needed and leaving well enough alone when things are at goal. Now let us go through high-yield stem recognition. For an initial visit stem, the patient is there to establish care, and the right answer prioritizes a complete history, baseline preventive screening, and a full medication and allergy reconciliation before any narrow workup. For a chronic disease follow-up stem, an established patient returns with a measured value above target while on therapy, so you compare the number to the goal first and then decide whether to intensify treatment or to continue and monitor. For a health maintenance stem, a well patient asks what is due, and you anchor on the patient age, sex, and risk factors. Then select the screening or vaccine recommended for that profile. These 3 stems repeat over and over on practice questions and on the real exam, so train yourself to label each one the moment you read it. Let us work through our first practice question. A 68-year-old woman comes to the clinic to establish care after moving from another state. She brings 3 pill bottles, but she also mentions she takes a water pill and something for her bones that are not among the bottles, and she is unsure of several of her doses. Before refilling any prescription, what is the most appropriate next step? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. A new patient establishing care with a medication list that is clearly incomplete and uncertain. She names drugs that are missing from her bottles and does not know several doses. That is a textbook medication reconciliation trigger. Step 2. Apply the rule. The board rule is to build one accurate and complete medication list before you prescribe anything. Gather every source, the bottles, the pharmacy record, and the patient report, and confirm each drug, its dose, and the reason she takes it. Reconciliation always comes before refilling. Step 3. Eliminate wrong answers. Refilling the 3 medications she brought acts on an unverified list and risks errors. Ordering a broad panel of laboratory tests is premature when you do not yet know her current drugs, Referring her to multiple specialists fragments her care unnecessarily. The correct answer is B, perform a complete medication reconciliation. Here is our second practice question. A 55-year-old man with no chronic medical problems comes in for a routine wellness visit. He does not smoke, drinks alcohol only occasionally, and has never had a screening colonoscopy. His blood pressure and body mass index are normal. He asks which screening test he is now due for. What is the most appropriate recommendation? Think through this one carefully. The key is to anchor on his age and his risk profile. We will walk through the answer next. Let us work through this answer. First, read the question carefully and anchor on the age and risk profile. This is a healthy average risk adult who has reached the recommended starting age and has never been screened for colorectal cancer, so that screening is clearly overdue. Now let us see why colorectal cancer screening wins. It is broadly recommended for average risk adults in this age range, and because he has never been screened, it is the test that is clearly due right now. Prostate-specific antigen testing is not automatic. It is a shared decision that depends on the patient's values. The abdominal aortic aneurysm ultrasound is reserved for older men with a smoking history, and this patient does not smoke. Coronary artery calcium scoring is a risk refinement tool, not a routine screening test. The correct answer is A, colorectal cancer screening. Let us review health maintenance scheduling for the boards, because this comes up constantly. The strategy has two layers. The first layer is to anchor on age and sex. Check blood pressure at every visit. Begin colorectal cancer screening in the mid-40s for average risk adults. Begin cervical screening in the early 20s for women. Begin mammography in the 40s to 50s depending on the guideline used. Match the test to the patient's age and sex before you do anything else. The second layer is to adjust for risk factors. A smoking history moves up lung cancer screening and triggers a one-time abdominal aortic aneurysm ultrasound in older men. A strong family history can move up the starting age for colorectal screening. The boards love writing a STEM where one risk factor changes the standard timing, so read the social history and the family history closely before you choose. Here is our third practice question. A 60-year-old man with type 2 diabetes returns for a routine follow-up. He takes metformin at the maximum dose and reports good adherence. His long-term blood sugar marker has risen to 8.9%, up from 7.6% 6 months ago. He has normal kidney function and no other problems. What is the most appropriate next step? This is a classic chronic disease follow-up question. Think about whether his value is at goal or above goal and what that tells you to do. We will walk through it next. Let us break down this answer. The classic pattern here is an established patient on maximum dose single therapy whose long-term blood sugar marker is rising and is now well above the usual target, even though he is adherent. That is a goal not yet met follow-up, and the pattern calls for intensifying treatment rather than repeating the same plan and waiting. Now the key distinction. Continuing metformin and rechecking in a full year leaves a failing plan in place for far too long. Stopping metformin and starting insulin alone throws away a drug that is still helping rather than building on it. Reassuring the patient and making no changes ignores a clear miss of goal. When a patient is adherent on maximum first-line therapy and is still above target, the next step is to add a second agent. The correct answer is B, add a second agent to intensify therapy. Here is a critical test-taking pearl about medication reconciliation. First, learn when to suspect that a question is really a reconciliation question. Watch for transitions of care, a new patient, a hospital discharge, a transfer between settings, or a patient who sees many different prescribers. Also watch for red flags like duplicate drugs, an unclear list, or a patient who cannot name their doses. Those cues tell you that reconciling the full medication list is the safest next step before any new prescription. Now, why this matters on the exam. The test frequently makes reconciliation the correct answer when the STEM dangles a tempting shortcut, like refilling or treating right away. Remember the core rule. Build one accurate list from every available source and resolve the discrepancies before you prescribe. Choosing to reconcile first prevents duplications, omissions, and dangerous drug interactions. That safety-first instinct is high yield and will earn you points across many different question types. That wraps up our review of outpatient clinic management test-taking strategies for Step 3. Remember to review the ambulatory medicine and preventive care sections in your primary review book and your question bank. Focus on telling apart initial and follow-up visits, managing chronic disease, performing medication reconciliation, and scheduling health maintenance, just as we did today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.